So this discussion is going to look at clinical decision making. So this is the first chapter in the pathology text where we kind of look at how we kind of go about clinical decision making as athletic trainers when we start to look at more general medical conditions or when you're thinking about non-orthopedic related issues that will certainly come up in your practice. So, as athletic trainers, again, our primary focus from an assessment standpoint are obviously orthopedic pathologies, but, in the kind of within that, you're going to encounter situations, and as a healthcare professional, it's important to be able to recognize when you find a non-orthopedic related issue. Sometimes you may think you're dealing with an orthopedic issue, and it turns out that you're not, because there are some things that could kind of masquerade as that. And we're going to go through this clinical decision-making process and kind of how you'll kind of manage your patients. Okay, so just some general things we look at as far as clinical decision makings when we look at athletic trainers. So first, just to talk about the difference between a sign and a symptom. Okay, so a sign is an objective thing that we see with a patient. Okay, so something that we could visibly see. So for instance, bruising would be a sign that we would see. Whereas and again, it's an objective thing, whereas a symptom is a subjective thing that a patient reports to you. So if a patient reports to you that they have difficulty breathing, that would be a symptom or a subjective thing that they're experiencing. You may also be able to, at the same time, be able to see that they're having difficulty breathing, but maybe, during your assessment, if you can't see it, they may still report it to you. That would be considered a symptom. So again, a sign is something that you see as an assessing clinician. A symptom is something that gets reported to you. A sign is, more of an objective thing. A symptom is more of a subjective thing. Okay. Your diagnosis deals with the specific issue causing problems. Now, many times, and pretty much in most situations as an athletic trainer, for the most part, when we're dealing with these general medical conditions, and a lot of times what you're going to encounter is more of what's called the differential diagnosis. And you'll talk about differential diagnosis because you'll also do this with orthopedic conditions. Sometimes at the end of your assessment, even with an orthopedic issue, you may not be able to narrow it down to one thing. You may have a differential diagnosis where there's a few possibilities, and until you refer to your supervising physician to get further testing, which will likely get done, that's when that differential diagnosis will get kind of broken down or looked at as far as being able to come up with the actual diagnosis. So the diagnosis is the actual specific issue that's causing the problems, whereas your differential diagnosis is, again, at the end of your assessment, if there are multiple issues that could potentially be causing the problem, that's where you would get into what would be called the differential diagnosis. The other thing that needs to be taken into consideration when you're looking at some of these general medical conditions in the various body systems is that many times, patients could have what we call coexisting or comorbid conditions. And these are conditions that, in addition to the primary problem that they're coming to see you for, may complicate some things. So that's something that is a part of your assessment that you're also going to have to kind of have in the back of your mind when you're looking at and assessing your patients. I'm going to be referring to tables many times throughout a lot of our discussions. So anytime I do that, and I won't necessarily always say, for instance, I'm saying table 1, 2. Many times I'll just kind of in parentheses put the label. So very important anytime I put that in any of these lectures, and you don't have to do it necessarily while you're watching the video and taking notes. You may choose to pause the videos and go back and look at the tables. Take a few minutes to look at them. However you feel works better. But here we look at the difference between clinical decision making and diagnostic reasoning, and this is kind of a nice overview when we look at an athletic trainer versus a physician and look at, so athletic trainers will do clinical decision making as a part of their, kind of day-to-day work when they're assessing patients, whereas, the physician will, again, do the diagnostic reasoning due to the fact that, the physician will, look to have various diagnostic testing done. And we also will see the difference between, what kind of goes on with the process. And again, some of these are very similar. When we look at the process of an athletic trainer doing an assessment and a physician doing an assessment, there are obviously going to be similarities, okay? An athletic trainer is going to do a history, a physician is going to do a history, an athletic trainer is going to do a physical exam, a physician is going to do a physical exam. An athletic trainer will come up with a differential diagnosis. A physician's going to obviously at times have a differential diagnosis, but again, they're also going to be able to confirm many things through laboratory and imaging testing, okay? And that'll be the decision of the physician because they can obviously put in requests for that. So just take a look at that and note the differences between the two practitioners and kind of, again, what we'd be doing. Again, obviously athletic trainers work under the supervision of a physician, and constant communication with how to kind of handle certain situations always makes for a good working relationship there. So here we're going to look at some theories of disease and stages of disease prevention. So one of the things we want to look at, obviously, is, again, anytime we could do prevention, prevention is a big part of what athletic trainers do. In reality, we could almost look at it as maybe even one of the most important things. If we prevent injuries, we prevent disease, we can really kind of halt a lot of things that could significantly impact a patient's life. So let's look at some theories of disease. There's various theories as far as disease is concerned. We have the biomedical theory of health and illness, which looks at the actual, for instance, abnormal cell, tissue, organ function. So this just strictly looks at, it's kind of what we call the biomedical model of pathology. So this just strictly looks at, kind of what is going on physiologically when we look at disease. Okay, so that's one area of disease that we look at. The psychosocial side looks at the psychological and social effects on the development and progression of disease. So again, some patients can't adapt psychologically when they experience injury or they experience chronic illness. So this is obviously something that's going to significantly impact how they kind of handle and how they kind of either recover or manage their issue, whether it's an actual physical injury, orthopedic related or non-orthopedic related disease. Then you have genetic theories, which focus on, again, errors in DNA and RNA replication. They look at how that contributes to pathology of disease. It looks at the immune system's response, how different individuals heal at different rates. Again, this brings us back. We know that there are a lot of conditions, and some of the conditions we're going to talk about are genetic disorders. Okay, so in other words, if your genetics predispose you to a certain illness, for instance, or medical issue, no matter what you do, you're always at a high risk. Okay, so for instance, you may be extremely healthy, you may be, have a high level of activity, eat well, but yet if you have a, history of cancer in your family or something like that, while you can certainly help yourself in prevention, it's not a guarantee. If your genetics predispose you to that, you're always kind of at risk. So if we look at disease prevention, there's kind of three levels of disease prevention. So, primary disease prevention just looks at reducing risk factors, okay? This gets to be especially all the more important from if we look at that genetic contribution to disease. So again, if you're already predisposed to, a certain type of medical issue, nutrition, exercise, going for, kind of just managing things in your life are things that can do that. Monitoring environmental risks, okay, educational programs are all things that are considered under that primary area. Next is secondary. So secondary looks at early detection of anything that may come up, okay? So, and early detection is very important, particularly for a lot of the issues we're going to be talking about, because the earlier they get detected, they can get treated. So kind of the interventions here involves just, regular medical checkups, self-examination, early medical treatment. So this kind of gets an individual more involved with their healthcare professionals in trying to do early detection. Okay, so for instance, most adults, even if they don't get sick over the course of the year, they usually see a doctor at least one time to do a medical checkup. So those individuals will go, will get at least what they call a well visit, where they'll just go and visit with their doctor, and many times the physician will order, blood work. There's yearly blood work, or maybe if there's something that, again, within their family that needs to kind of be monitored for, they'll kind of keep an eye on those things just to sort of, again, work to a degree of prevention. Then there's what's called tertiary. So, ideally we don't get too deep into the tertiary aspect. So once we get to the tertiary stage, that's where we have to limit an established disease. Okay, so this involves the actual medical treatment once we know that a disease is present. Now, again, many times you can go through, as I discussed, you can do all your primary and secondary, and the unfortunate thing is you may still succumb, or you still, may end up getting diagnosed with a condition. Again, the role of genetics and everything involved with that. But at least if you do the primary and secondary things, even if you fall into that tertiary stage, then the medical treatment is all the more effective, and your ability to recover, your ability to cope with the illness gets a lot better. So it makes the treatment and then those supportive measures better once you get to that point. Many times with a lot of these, with a lot of the things we're going to talk about though too as well, primary and secondary could sometimes stop the development of a disease. So, those are all things to look at. Again, it can't be all the time, but that's where the disease prevention falls in much of this. So now we're going to get into the actual components of the assessment and the actual clinical decision making that takes place. Okay, so we look at the medical history. So a history is going to be very important in kind of being able to, sort of start to, put puzzle pieces together as far as what could be going on. Again, you're already going to be starting to think about what could possibly be wrong, because this is going to guide your assessment. The better you get with a medical history, the more efficient the rest of your assessment really becomes. Now, again, sometimes the medical history can seem really clear cut just based off of what they're telling you. However, sometimes this can be hard. You also have to be understanding that, the patient may be kind of, dealing with, again, their own psychological stresses and trying to communicate information. People have different ways of communicating when they're under stress, and that could be there too. So you also have to be sensitive to that. So we look at the purposes of the medical history. Again, we're looking to determine if a potential disease or injury exists. We want to make sure we identify any coexisting conditions. Does the person have anything in their medical history that may guide you? We can start to kind of determine the stage of the injury. We could also kind of determine any possible contraindications to any treatment that we have. Okay, so those are some things that we kind of want to look at as a part of the medical history. So when we take a medical history, again, we have different components here. We have our chief complaint. That's going to be primarily what they're coming to see you for. So all your patients are going to have a particular reason to come and see and talk to you. You have the description in the course of the illness. They're going to kind of go through, what's been going on, some of the symptoms that they've been having. Again, you can see I have up here again a table denoted. So again, anytime you see this, I want you to go back and look at, because again, the one nice thing I really like about the text is kind of the breakdowns they have with these tables, so make sure you go and look at that. You have the family medical history, okay? So again, when we're looking at more general medical conditions, kind of knowing, a family history could be very relevant when we're looking at a lot of these issues. And then we have a review of the symptoms, okay? Or I'm sorry, a review of the systems rather. So a review of the systems looks at a screening for basically all your major organ system disease by asking about specific symptoms, okay? And again, you can see on here what we're going through. And that's going to be really important. And again, a big part of what we're going to be doing in this course is looking at the different systems of the body and kind of almost doing we're always going to do a general review of the anatomy and physiology of the organs and everything and all these various body systems, so that you could kind of see when they, when there's issues that are going to be occurring with any of them. The other nice thing that a history can do is, individuals may have what are called occult pathologies. So an occult pathology is an undetected pathology or something that may not be obvious. So as a part of your medical history, that could come out. Again, you're also going to be able to learn things as a part of their recent general health, which will talk about things like, do they smoke? Do they drink alcohol? Other general things about their life that could possibly contribute regarding their recent general health. So when we look at symptoms, okay, again, so when we look at just the symptom of pain, so pain is going to be one of the more common things people have with many of the things we talk about. And again, it's going to be important to be able to differentiate between different systems in the body. So obviously we know from, again, I'll relate things back to our orthopedic assessments. Obviously as a part of our orthopedic assessments, many times patients are coming to us because something hurts. Well, again, we also have to be able to determine if, is that issue coming? And again, sometimes it's going to be a lot more clear cut. If someone has an acute situation happen, they have a severe inversion ankle mechanism, we know that they sprained their ankle. They likely don't have some systemic pathology happen. But many times when you have more of a more insidious onset type thing, it should always be in the back of your mind. Again, sometimes it's a little more obvious than others, but that's something you want to look at. But here you kind of see differentiating between different systems when you're looking at pain that they might be having and talking about different types of pain. So for instance, vascular pain, for instance. So many times vascular pain has a descriptor of being like a pulsing or a pounding pain. Or many times with vascular pain, they may describe like cramping symptoms. They may be talking about cramping. So again, you can differentiate and apply that based upon the history and how the different systems are kind of presenting as you're going through, okay? And again, there's some examples of that in that table. You could also look at acute versus chronic pain. This is something that we talk about in the modalities class, talking about different types of pain, what causes different types of pain. So again, acute, again, classically you think about sharp, stabbing type pain. That's usually more acute pain. Chronic pain we typically associate with being more dull. Local versus referred pain. So local pain looks at pain being in a particular area. Referred pain is pain in an area that may be that's not associated with the actual area of pathology. So that's something to note as well. So referred pain is going to be pain somewhere else in the body versus local pain, which is pain right exactly where the actual pathology is taking place. Then you have constant versus intermittent pain. Now, this is usually something that when we differentiate, if we're ever in a situation where you're trying to differentiate, so is this a structural kind of orthopedic pathology, or are we dealing with a general medical issue? This is one way you could sometimes determine the difference between the two. So many times systemic issues have constant pain. Okay, so in other words, the pain doesn't change with movement. Regardless what position they're in, it hurts. Many times the pain gets worse at night, okay, when we're talking constant pain or pain due to systemic pathology, whereas with musculoskeletal issues, typically the pain's intermittent. We can associate pain with movement, okay? Usually the pain gets relieved with rest. Now again, sometimes with a musculoskeletal injury that's acute, they may have some lingering pain even at rest, but typically, again, we're just looking at common things that differentiate between the two, okay? Usually musculoskeletal pain doesn't cause pain at night. Okay, so again, pain at night also kind of makes you start to think, okay, is this an orthopedic pathology or is this more of a systemic issue? So those are things to always keep in the back of your mind when you're going through any assessment. So looking at symptoms, again, we want to look at, well, what causes pain? We have different types of pain. So we have mechanical pain. Okay, so mechanical pain is when you actually have, for instance, our anatomical structures, anytime they're under abnormal physical load. So if we look at this picture, we see an anatomical structure that's under an abnormal load. Well, that abnormal load is going to put mechanical stress on the tissue. That's going to cause pain. Okay, we also have chemical causes of pain. Okay, so the chemical causes of pain, when substances get released, we talked about the healing process and modalities, okay? The acute inflammatory process. Substances get released into the tissues and into the intracellular spaces that cause pain. These substances are going to irritate issues. They're going to irritate nerve endings. That's going to cause pain. So if you think about those chemicals that get released during the acute inflammatory process, that causes pain. There's also perceptual causes of pain, okay? So pain itself is a perception. We talk about how individuals, no two individuals are going to respond to pain in the same way. So pain has cultural, social, personal experiences are all going to influence pain. We look at this picture, this is obviously an extreme, very serious injury. How that individual is going to respond to pain is going to be based upon his past experiences of pain, okay? And just his general perception of it, okay? Now we look at that and we see, well, that's a pretty serious injury. Most people are probably going to have, but even within that, there's going to be different responses. Now, we have different pain-generating tissues in our body. So, we have three that we're going to talk about. So we have cutaneous pain, okay? So cutaneous pain is your skin and subcutaneous tissue. Obviously, anytime there's damage to that causes pain. We have deep somatic pain. So anytime you hear somatic, that refers to the structure of the body. So deep somatic pain, comes from bones, nerves, muscles, tendons, ligaments, arteries, joints. Okay, that's our deep somatic pain. Deep somatic pain could cause an autonomic reaction. So again, our autonomic reactions, our autonomic nervous system is what controls our pulmonary system, our digestive tract. Deep somatic pain could cause issues with the autonomic nervous system. Okay, for instance, if someone has an injury and the pain's really causing a lot of stress, that can have detrimental effects to the autonomic nervous system. Then you have visceral causes of pain. So visceral pain receptors are coming from our, for instance, like our abdominal organs. Okay, so the viscera refers to our organs. Now, the interesting thing about visceral pain is that, visceral pain receptors typically end up getting referred to dermatomes. So in other words, many times the visceral pain receptors are going to send pain information to somewhere else. This is where that referred pain is going to come into play. So we'll talk about, for instance, how certain abdominal organs will refer pain to different areas of the body and how that's a sign that, something else, that's a symptom that a patient will report that, kind of clues you in as to, what could be going on. Again, you obviously want to look at the big picture and some of the other things that they're reporting to you, but that starts to clue you in as to, what possibly could be involved there. So we look at our physical exam techniques, and again, all the different areas of the body are going to have different, kind of important points to look at when you're looking at the physical exam. So you're going to do your inspection. So the inspection is going to be your general observation of various things. For instance, here, if you were observing this patient, there's some obvious things that jump right out at you from your inspection. Then you're going to look at vital signs. So vital signs: heart rate, respiration rate, blood pressure, body temperature. Anytime you go to a physician's office, you know that these things always get done. Okay. Many times in emergency situations, these are going to be important things to look at. Again, if a patient has a past history of hypertension, cardiac pathology, vital signs should always get recorded. Okay, so you always want to make sure you're tracking that. Percussion and palpation. So percussion is a striking over bones, over abdominal organs that can tell you some things about those individual tissue structures. Palpation is just literally just your touch. Okay, you're using your hands to try to feel for different things. You're going to do superficial palpation, deep palpation to be able to determine any type of issues or abnormalities with your hands. And then auscultation is with an instrument. We know we use a stethoscope for that. That's going to help examine the heart, the lungs. You can also assess various important vascular areas in the body. You can listen to the abdomen for bowel sounds. And again, we're going to talk about specific auscultation when we get into the various regions where that becomes an important part of the assessment. So other physical exam techniques, and again, some of this becomes really important when you start to look at, again, where it'll fit in will be based upon what body system we're looking at. So when we get into the different body systems and the pathologies involved, this will all kind of come out with that. This is just your general overview, as I've been saying. So smell is an interesting thing because, you can use smell, many times some things associated with endocrine function, and I'm talking smell from the assessor's standpoint. Also, many times, for instance, an infection can create smell. So, if someone has a wound that's infected, that can actually also put out a smell. That could put out a smell. So that could kind of tell you again that there's a bigger issue there. Your neurological screen. So there's various aspects of the neurological screen that you're going to do. We do neurological screens a lot of times, particularly in orthopedic assessment. So this really isn't going to be anything too new. Cranial nerves and reflexes are going to be an important part of the neurological screen. Sensory testing for your dermatomes, motor testing for your myotomes. So, the motor testing is going to be important to kind of help you differentiate between, if you're looking at a neurological issue, do you have a nerve root issue? Is it a peripheral nerve issue? How is a muscle working, from the standpoint of the nervous system? So those are all parts of the neurological screening. So, going back up to the cranial nerves. So cranial nerves control smell, vision, they control eye, they have eye control, various functions. Many times you're going to be doing that as a part of your, for instance, your concussion evaluation. We always test for cranial nerves. Reflexes or your deep tendon reflexes. And again, we'll talk about all of these. You have your biceps at C5, your brachioradialis at C6, triceps at C7, the patella L2 to L4, and your ankle test for S1. You also have things like the Babinski sign, which is an abnormal reflex that happens when the motor tracts from the brain to the limbs are disrupted, and that many times occurs with a spinal cord injury or severe head injury. So those are all things that you're going to want to be, again, testing for as a part of your exam. So again, differentiation. So again, many times, patients are going to come to you. They're going to have various things they report on. You have to be able to differentiate things and kind of know when referral does need to take place. And there's different types of referral. There's immediate referral to an emergency room. There's urgent referral that gets done within, a short period of time. It's not urgent to the point where they're going right away, like an emergency referral, where you do that. How the patient presents and what they report to you. So again, if something's a medical emergency, so again, here we're going to know there's going to be a point within your assessment, particularly when you're dealing with an acute situation, where you know right away that maybe necessarily a complete, specific diagnosis doesn't have to take place, because they're going to need to go somewhere and get treated. So these are going to be the things that kind of denotes this. So you're basically at this point going to either stop your assessment, or you're going to either in your monitoring of a patient decide to change course and kind of manage them from an emergency standpoint. So anytime you have rapid changes in vital signs, okay? So if you're kind of monitoring a patient's vital signs and all of a sudden they just change out of nowhere, okay? So if maybe you have, if you're working in a, common athletic training setting, you're on the sidelines, you're monitoring a patient for whatever it might be, and part of that's their vital. If all of a sudden their vital signs become extremely abnormal, they need to be, that's a medical emergency, and they need to be referred. Anytime someone's in shock, it's a medical emergency. A non-traumatic syncope or loss of consciousness, okay? So that would be considered a medical emergency. Profuse bleeding, abdominal rigidity or severe pain, prolonged unexplained diarrhea or nausea, vomiting, and then seizure, okay? Those would be some things that would constitute a medical emergency. Again, important corresponding signs and symptoms. So on table 1-2, these would be things that would be medical emergencies where you'd immediately activate your EMS. Okay, so again, take a look at that table. Again, they will kind of coincide with some of the things. So they basically, the examples I gave, they kind of break down and show you what are some of the signs and symptoms and the kind of management of what you would be looking at there. So with that, you would also have your red flags. So when we look at symptoms, red flag symptoms, again, this is another situation where, again, referral will take place, because you're going to need to do some diagnostic reasoning in conjunction with your supervising physician. So again, I have some red flag. I have the tables denote it, but just to kind of go over some examples: constant pain, heart palpitations, fainting with no particular cause, night pain or night sweats, visual problems, unexplained weight loss, severe shortness of breath, recurrent nausea, vomiting, difficult or painful urination, blood in urine or stool, excessive malaise or fatigue. Again, it doesn't necessarily mean that something serious has to be happening. It just means it needs to be ruled out, okay? In all likelihood, you'll encounter a lot of, patients that'll come to you with what are red flag symptoms, but, upon further testing and everything, it turns out that, what would be, a big concern maybe not be the case, but you never want to miss them. That's the important thing. So you certainly don't want to ignore these, okay? So it would be important to make sure that the appropriate referral takes place there. So the seriousness of the condition, this kind of coincides with what I've been talking about from an assessment standpoint. When you look to, if you're going to refer a patient, which referral are you doing? Okay, are you doing in a, are you activating EMS and getting them to a medical facility right away? Are you maybe getting them to a physician within, 24, 48 hours, or is it something that you're kind of holding off on? They're just going to kind of do, typical, referral. So we look at the hierarchy of concerns. What are the hierarchy of concerns? So if you just think of just general emergency assessment that you've kind of been taught already, there's really not a whole lot different here per se. Your vital signs are always the most important, okay? The cardiovascular and respiratory system need to be functioning, okay? So that's the most important. So your vital signs. So if you get changes in heart rate, respiration rate, blood pressure, body temperature, that's your immediate concern. Okay, you can't sustain life without the cardiovascular and respiratory system functioning. Okay. Next, you have brainstem and neurological function. Okay. So the brainstem, smell, visual, vision, facial sensation, all the different things that are covered within a assessment of your cranial nerves. Okay, that's important. Your neurological function, your reflexes, coordination, does the person present with any ataxia? Do they have balance issues, sensation? Okay, that kind of becomes next. Next, you have endocrine and metabolic function, okay? So, some of the things associated with that, many times things from like dehydration could be present. Are they lethargic? Are they fatigued? Do they have unexplained edema? That could be something that would be related to the endocrine metabolic system. That could also be a cardiovascular issue as well. So again, sometimes things could tie in. So, you could kind of look at their, you'd obviously want to look at vital signs as well if you were dealing with that. And then just look at daily functions, okay? So how are they sleeping? How are they eating? Do they have, and that'll kind of coincide with the endocrine and metabolic too. Loss and, if they talk about having a loss and gain of body weight, we obviously want to look at the endocrine and metabolic system. But that also ties into their daily function as to, how they're eating, what they're eating. Again, bathroom habits, things of that nature would fall into the daily functions as well. So again, differentiating, general medical pathologies from a musculoskeletal injury. So again, some of the things we have to look at, and this is where, something as a sports medicine professional, you don't want to miss things, okay? And the idea behind this isn't necessarily that you're always going to know what the disease is. Again, think physicians have to use testing to confirm their diagnosis as well anyway. So again, you're not necessarily looking, but you may be, or know what's going on, but you may suspect something, okay? So confounding symptoms are symptoms that could sometimes get confused with musculoskeletal pathology, or there's musculoskeletal signs or conditions that, could be kind of disguised, and you may end up kind of confusing that. You may be treating somebody for what you think is an orthopedic condition, and it turns out more of a general medical condition could be taking place. So for instance, someone with back pain, so they come to you and they say, well, my back really hurts. But then as a part of your assessment, you find out, well, they have a lot of pain with rest, they have nausea, they have cough, they have a palpable pulsating mass in their abdomen. Well, their back pain isn't going to be caused by a facet joint dysfunction, okay? So that right away tells you that, okay, they came to me for back pain, but as a part of your assessment and, in your history and talking to them, you find out that they have all these other things. Obviously here we're dealing with a potentially more serious, systemic pathology, okay? Now this is a kind of an obvious case. Sometimes it's not going to be that obvious. So you have to kind of be, again, paying attention to things that your patient's telling you as things come up. So again, issues by organ system, and I'm just going to list these. Again, we're going to be looking at all of these different systems, but I want you to review these charts. I have posted PDFs, and I'm not going to do this every time in every chapter, but for this chapter in particular, because there's a lot of these, I did post PDFs on Blackboard that you can also use. Again, if you want to use them, you can. If you don't want to use them, you don't have to. But there are things that, they're tables and stuff. If you want to put them, if you're keeping a separate notebook, you can always put them in there as well. But make sure you review those. Again, you're going to be responsible for this from a testing perspective. So for instance, when you look at the gastrointestinal and hepatic disorders, they just kind of go through some of the conditions. We're going to go through the conditions more in depth as we get to the chapter, but on that system. But it could kind of, again, start to get you into that mindset of what are you looking at with each of these individual body systems. So systemic pathology and body regions. So again, different areas of pain that we could be, kind of looking at. So for instance, when we, look at different areas of pain, they can kind of tell you or start to give you an idea as far as what could be going wrong with the individual. So for instance, if we look at arm pain, pain in the left arm versus pain in the right arm, those could be, those are different pain referrals for very different areas of the body. So again, actually, at the end of this, I do have the table listed. I'm just looking at my notes right now, so I won't get into that. So again, look at arm pain, leg or groin pain, back or thoracic pain. So again, these are going to be areas of pain that can get referred to through various pathologies. Neck pain, multiple joints or sites can tell you that there's various issues, weakness or fatigue. again, so if you go and look at your table here, look at what systemic issues are related to these different areas of the body. So for instance, I'll talk about one right now. Pain in the right arm many times is indicative of a liver injury. So if you have a patient, again, say you're providing coverage at a sporting event and they took a direct blow to the abdomen, and all of a sudden they start to tell you, well, I'm having this pain in my right arm. The pain in their right arm is likely, if they took a severe enough blow to the abdomen, could be caused by a liver injury. So that's something important to note. So kind of note the areas, the various areas. And again, sometimes it makes a little bit more sense than others when you're looking at referred pain. With certain pathologies, sometimes it seems a little weird, but it's still, if you have kind of a background on this, it really helps with differentiating between different things. And again, these are just your learning outcomes, so a little outline as far as what's important to know. Again, probably one of the even more important things, again, review those tables. Again, one of the reasons why I do really like this textbook for this particular information is that they do have a lot of tables and various visual aids that are very helpful with kind of learning this material.